So in next 12 minutes, I'll be talking on how to define frailty in your 6 cirrhotics and how to measure frailty in your practice and what are the strategies to optimize severe frailty in your cirrhotics. So coming to the definition of frailty in cirrhosis, global frailty is defined as a distinct physiological syndrome of decreased physiological reserve. And here, your patient has got a reduced physiological reserve, and that makes him increasingly vulnerable to the health stressors, and there is adverse health-related outcomes. So, when your cirrhotic is robust or when he is frail, and he gets an acute insult and leads to decompensation, in a frail cirrhotic, it leads to a situation where there is adverse outcomes. It leads to a situation where the patient goes on to get recurrent infections and patient goes on to get recurrent decompensations till death or transplant. Whereas in a robust cirrhotic, acute decompensations, many of the time these patients will recover to a state, to a recompensated state where they recover spontaneously. And when you talk about definitions of frailty in cirrhosis, it's mainly phenotypic definitions. And we know that there's an interplay of malnutrition, sarcopenia, and frailty in your cirrhotics. The malnutrition is defined as an imbalance of nutrients, and it along with immobility can lead to sarcopenia. And sarcopenia, the phenotypic manifestation is as impaired muscle mass. So a sarcopenic cirrhotic with malnutrition and immobility can lead to frailty. And frailty in a cirrhotic is phenotypically defined as an impaired muscle function. So your patients with malnutrition and sarcopenia can have frailty, and frailty is defined in cirrhotics as an impaired muscle function. And why should we be worried about frailty in your cirrhotics? Because it is associated with twofold increased risk of waiting mortality. There's an increased risk of hospitalizations and mortality in your patients on the waiting list. There's a poor quality of life in your cirrhotics, and it leads to higher mortality and poor recovery after liver transplant. I'm sorry, the slides are somehow outside the. And this are 2 studies from the UCSF group by Jennifer Lai. And the first study, you can see that patients with frailty has got an increased mortality independent of the presence of decompensating events like hepatic encephalopathy or ascites. So any patient with hepatic encephalopathy or ascites, if they are frail, they've got a twofold increased risk of mortality compared to patients who are not frail. And in the second study, they showed that if we can improve the frailty, by 1 point, then there's an improvement in the mortality in the waiting list. And this is a study by the same group in post-transplant patients that showed that frailty was associated with a twofold increased risk of mortality in your post-transplant patients. And there was an increased incidence of prolonged hospital stay, prolonged ICU stay, and prolonged utilization of hospital resources in patients who are frail. What causes frailty in your cirrhotics? The frailty in cirrhotics can be due to hepatic causes and non-hepatic causes. And we know that we are seeing more and more patients who are elderly in our waiting list, more and more patients who are NASH or metabolic dysfunction related cirrhosis with comorbidities. And we are seeing more and more patients who are very sick in our waiting list. So advanced age, the comorbidities and advanced liver disease, all these predispose to a very sick, frail patient in our waiting list. And associated with that, it has got the liver-related factors like the presence of DAMPs and PAMPs leading to systemic inflammation, leading to a catabolic state. And you have got alcohol-related cirrhosis where alcohol per se can lead to sarcopenia and frailty. And there is decreased testosterone in most of your patients, and there are got multiple endocrine and metabolic dysfunctions in your cirrhotics that can lead to sarcopenia and frailty. So how do you measure frailty in your patients? The classical test has been the eyeball test, but it's highly subjective. There's inter-observer variability, and it's not reproducible. So we need some objective tests, and for assessing global frailty and physical frailty and sarcopenia, there are a whole lot of tests that has been described in the literature. And the American Society of Transplant, they have a expert committee on frailty in liver transplant and small intestine transplant. And they have come up with 4 tests that can be used in clinical practice. And 2 are subjective and 2 are objective. The subjective tests include the Karnofsky performance status and activities of daily living. And the objective tests are the 6-minute walk test and the liver frailty index. Both Karnofsky's performance status and activities of daily living has been validated in inpatient settings to predict waiting list mortality as well as mortality after liver transplant. And this is a subjective test, but these are the only two tests that are validated in the inpatient setting for predicting mortality in the waiting list and post-transplant mortality. And two objective tests are, one is a 6-minute walk test where you look at the distance that a patient can walk in 6 minutes, and if it's less than 250, it's a severely frail patient, and more than 350 meters, the patient is robust. The most validated test in the outpatient setting is a liver frailty index. It has got three components. One is the hand grip that looks at the nutrition. The second is the chair stance that looks at the muscle strength. And third is the balance, where you look at the neuromuscular coordination. And based on these numbers, and you have a online calculator where it gives you the score. The score is more than 4.4, then your patient is frail, whereas the score is less than 3.2, your patient is robust. And the study by Jennifer Lau using liver frailty index has shown that for the same MELT, if you have two patients with a MELT score of 14, and one is frail and one is robust, the patient who is frail will have a twofold higher mortality than patient who is robust. So any patient when the patient with same MELT score, the mortality varies if they are frail or robust. So coming to the classification of frailty, again, in your clinic, you can classify it into mild, moderate, or severe based on these 4 scores. And if the ADL, you can use either ADL, KF, Karnofsky performance status in your sick ICU patients who cannot do objective scoring, and in your outpatient, you can use the 6-minute walk test or your liver frailty index. And based on the scores, you can classify them into mild, moderate, and severe. And coming to the question of how do you optimize your patients with severe frailty, we come to a concept of rehabilitation where it's initially came in surgery, where the process of enhancing functional capacity prior to surgery to improve tolerance to the upcoming physiological stressor. So by prehabilitation, you are trying to improve the physiological reserve of the patient so that you can improve the physiological reserve of the patient so that he can overcome the acute stresses of acute decompensation and as well as the liver transplant. And in a context of cirrhosis, we are looking at, by prehabilitation, we are looking at improving the nutrition status, the muscle function, and the muscle mass, so that we can improve the outcomes on the waiting list, we can improve the post-operative outcomes, as well as improve the quality of life of the patient, both pre and post-transplant. And the main pillars of prehabilitation are exercise training, nutrition, and the physiological support. But in addition, in cirrhotics, as I said, you need to prevent and treat the decompensating event, because decompensating events like hepatic encephalopathy can lead to reduced nutrition intake. The high ammonias can lead to further muscle loss. So, and ascites, again, if you have got those ascites, the nutrition will be poor. So, you have to prevent and treat the decompensating events in your patients with cirrhosis. And also, you have to optimize the extrahepatic organ functions, as well as you have to take care of the endocrine and metabolic derangements. You have to correct the diabetes, you have to correct the thyroid, you have to correct this hypogonadism, and you have to treat the metabolic derangements like the hypophosphatemia and hypomagnesemia in your cirrhotic. So all this should be tailored to an individual patient. So you have to tailor, you can't just have one size fits all approach. It has to be tailored to an individual patient so that it's feasible, a patient is adherent to it, and the patient has a good outcome. So coming to management of frailty in our practice, so first is the lifestyle interventions. You ask the patient cease smoking, cease alcohol, then psychological support, as well as increase the physical activity. Then you try to restore the liver health. That's the most important. And you treat the underlying etiology, ask the patient stop alcohol, treat your hepatitis B and C, treat your autoimmune hepatitis, treat all the comorbidities, control your diabetes, ask the patient to lose weight if possible, and optimize the management or prevent the decompensating events. You have to prevent decompensating events, so you have to try and manage the decompensating events early, and try to time the tips and transplant before the patient becomes very frail and deconditions. So in your patients with refractory ascites, try to plan the tips early so that they are not in a severely frail state when they go for a tips, and you time the transplant early in your patients so that they are not frail when they go into the transplant. Now coming to the 3 main pillars, first is nutrition. You have to prescribe nutrition to all your patients with cirrhosis, irrespective of whether they are for transplant or not, and you have to get the help of a dietitian in your clinic. Normally in our clinic, we don't measure the indirect calorimetry or direct calorimetry. We go by subjective measures. Like in non-obese, we give around 35 kilocalories per kilogram per day. It may range from 28 kilocalories to 37 kilocalories per kg per day, and that's a usual resting energy expenditure for your cirrhotics, average cirrhotics. But now that we have seen more and more of metabolic syndrome, we are seeing more and more of sarcopenic obesity, and so you might need to get the patient to lose some weight here. If the BMI is between 35 to 40, then you can ask a patient to take 25 to 35 kilocalories per day. And if the BMI is more than 40, then again the calorie intake can be reduced to 20 to 25 kilocalories per kg per day. But mind you, when you're doing a calorie restriction, always get your dietitian on board. Make sure that patient is on adequate amount of protein so that he doesn't lose muscle mass, and always ensure that patient is doing a resistance and a aerobic exercise. So you have to have your physiatrist and your dietitian on board when you are dealing with sarcopenic obesity. The protein intake is normally around 1.2 to 1.5 gram per kg per day, and in critically ill patients it may be increased up to 2 gram per kg per day. Don't restrict proteins even in your cirrhotics who have got hepatic encephalopathy, grade 3-4 hepatic encephalopathy. And always time the feeds, because cirrhosis is a state of accelerated catabolism. So don't make the patient starve more than 4 hours. You can either have an early breakfast or a late night snack. So depending on what the patient chooses, he can either have a late night snack or an early breakfast. And always take some small snack every 4 to 6 hours to prevent prolonged fasting. The role of BCCA and L-carnitine is controversial. Even though there's good pathophysiological basis and animal studies to show that they benefit sarcopenia, large systematic reviews and meta-analysis don't show any benefit for BCCA and L-carnitine in your patients with severe sarcopenia. You can use them in patients who are on are not maintaining weight in spite of protein supplements, and who are not achieving the targets of muscle mass in spite of good protein supplements. Always prescribe the exercise. Don't just say to your patient that do some exercise. Always prescribe the exercise, and make sure, look at the safety, whether the patient can actually do it, and assess the safety before you prescribe exercise. And in your outpatients, you should always prescribe exercise, and you should prescribe the frequency, intensity, type, and time of exercise, so that you can follow it up later and see if the patient is achieving the targets that you have set, and whether you need to increase the targets. And if possible, always get a trained physiatrist involved in the exercise prescriptions. And some of the, other than exercise and nutrition, some of the features, hormonal and metabolic targets that are being tried. One is L-leucine and L-citrulline supplements. Again, these are under trial, and there are no guidelines to use leucine or citrulline in your transplant, in your cirrhotic patients. And supplementation of testosterone, a single study by Sinclair that showed that supplementing testosterone in patients with cirrhosis who have got low testosterone levels in their blood. The study showed that there was improvement in the muscle mass as well as reduction in the fat mass in patients who were given testosterone. But routine use of testosterone is not recommended because of the increased risk of HCC as well as increased risk of thrombosis in your patients. So finally, we need to, coming to your 6 cirrhotics in the waiting list, we need to have objective frailty tool tests that are incorporated in your pre-transplant evaluation. And based on the objective tests, you classify the patient into not frail, moderately frail, or severely frail, and plan the management accordingly. In most of your severely frail patients, most of these patients are admitted to your floor or to ICU. And all what I said about prescribing exercise would not be possible in these patients. The exercise pattern, that exercise prescription that we discussed are mainly for outpatients and not for your very sick, frail patients in the ICU or in the wards. And what is possible would be to get the physiatrists involved and get them to have active and passive mobilizations, get them mobilized early out of bed, and then have chest physios. And some of these patients might need tube feeds because they are not, your targets of nutrition are not achieved by oral feeds. And At times when there is gut failure, you might need a parenteral nutrition, and we might use some of these patients, very sick patients, we might use IV, BCCA or Lola supplements to improve the muscle mass. And always in very sick cirrhotics, the prehabilitation has to be continued post-transplant till the patient gets discharged. To summarize, the frailty is common, and we need to incorporate tools to objectively measure frailty in your pre-transplant evaluation protocols, and we need to have a plan to have a multidisciplinary approach that includes a dietitian and physiatrists to improve the frailties in your very sick, frail patients. Thank you.
Thank you, Dr. Charles. In a severely frail patient, would you consider that patient for liver transplantation? And if yes, how long do we wait for optimization?
When you talk about very frail patients, most of these patients are ACLF patients who are very sick in our wards. And frailty alone would not be a criteria by which we say no. So we take everything into consideration before we say no. Because most of these patients, ACLFs in your ICUs or in your wards, they can't wait for 2 to 4 weeks for the frailty to improve. And most of the time, whatever said and done, they don't achieve the improvement that you need. But
very nice talk, Dr. Charles. Do you have a sort of, priority for the protein supplement? What kind of, like should be a supplement which is commercially available or the natural one?
I did not get your question.
See, when we are asking them to take proteins, what form? Like, would you like to add the supplements which are available, or we should go for the natural products?
No, normally if the patient can achieve the protein intake by the natural foods, that would be the best. And if they can't achieve only, then we supplement it.
But we should be keeping a tab of it.
Yeah, we should be. That's why we should always, any patient on the waiting list, we normally get the dietitian involved and keep a tab of it.
So the patient with ascites, so you said that we should manage the ascites. So does it include giving albumin periodically and doing a ascitic LVP also? Or just medical management will be enough?
No, the problem with the large volume, if the patient has got a gross ascites, most of these patients can't take food. They will have nausea, anorexia. So the nutrition intake will be very poor. So a large volume paracentesis always helps. And there are some studies that have shown that large volume paracentesis reduces the resting energy expenditure also. And there's some controversy about furosemide. That's saying that it increases the muscle loss, and so the dose should.
It is individualistic for each patient. You have to decide depending upon his clinical situation how to manage ascites.
Pardon?
Like it should be individualistic.
Yeah. It should be individualized, but see, most of the patients, I think patients are getting recurrent ascites. I should go for early tips or a transplant before they develop severe sarcopenia.
Okay. And salt restriction?
Yeah, 4 grams salt for all patients. Salt to improve the palatability, because restricting too much salt also will lead to reduced intake. So salt to improve the palatability, the albumin, your diuretics. At times we admit the patient and then put them on terlipressin and albumin infusions to get the ascites under control. But if the patient is not getting controlled or patient getting recurrent, you don't have to wait for frank ascites. If the patient is getting recurrent ascites more than 3 taps a month, then such patients should undergo at least early tips or a transplant.
Thank you.
Charles, that was a nice talk. But have you ever used testosterone in your clinical practice?
No, we don't. We have given it for patients severely cachexic who are not for transplant, and for patients with hepatocellular carcinoma who are severely cachexic. And oral androgens are being used in patients, severely cachexic patients who are for HCC, because I have seen our oncologists use it a lot. Thank you.